All right. Well, we will go on and get started. I am Lindsay Wiley. I'm the Executive Director at the Oklahoma Foundation for Medical Quality. We are working in tandem with My Health Access Network, and I'm going to introduce our speakers today for the HIE office hours. Thank you guys for joining. We do have two presenters today, and I'm happy to introduce them. First, we have Mr. Stephen Miller. He is works for the state coordinator for HIE. And then we also have Mr. Dr. David Kendrick, who is the CEO at My Health, and they both have many other titles and are over many other people, but we'll keep it simple today with Steve from the state as the executive over the HIE, and then David Kendrick, the CEO of My Health. Thank you guys so much. And I'm going to go on and turn it over to you, Steve.
Okay,
Thank
thank
you.
you. Thank you so much, Lindsay. Yes, yeah, as Lindsay said, I am the Chief Technology Officer for Oklahoma Healthcare Authority and the state coordinator for the HIE. And we're going to take you through a little tiny bit on the history but mainly some of the features and capabilities and some of the incentives that are out there now that are very beneficial to practices in this session. So with that, I'm going to go ahead and share my presentation. 1 second. All right, everybody seeing that?
Yes, we can see your screen.
All right,
Yep.
great. Okay, I will go ahead and get started. So just going to go through a little bit about the Health Information Exchange, what it is, why we need it, a little bit of the history, some common questions, some how the legislation's worked, but mainly want to talk a lot about the HIE incentive programs, what eligible providers can access those, and a big part of this is the progress we've made over the last couple of years, capabilities of the HIE, which Dr. Kendrick will walk through, and some of the value for providers. So I like to just point out some, not only why, but also what the Health Information Exchange is. And I pulled this, I've kind of over time collected this of many definitions, but this is probably the best one I found. And the big thing I like about this is these pieces I have highlighted. The first thing is that the HIE is a very secure system. Actually, the technology and the processes and companies that operate the Health Information Exchange are HITRUST certified. That's the highest level of cyber certification that you can obtain. And they've done a great job maintaining that security over the last 10 years. I also like to point out that not everyone can just willy-nilly get in the HIE. You have to be a provider involved in the care of that patient. You actually attest to that when you actually enter the HIE of what kind of relationship that is. And it's all according to HIPAA. So all the rules that you'd see typically in your office around HIPAA and records sharing and records disclosure are all the same within the HIE. The other thing I'd point out is this adheres to all relevant state and federal laws. And so this makes for a very, very secure and very good system to work in. Now, you might say, why do you need it? Well, if we have an HIE, we can reduce healthcare costs associated with redundant testing, being able to see that patient, see what other test results they have. Maybe they just had an MRI at one facility. You want to see that at another facility. All that data transfers and is available within the HIE. It can also help reduce hospital readmissions and emergency department visits. And the big thing we do, and I think one of our main use cases is improving care coordination. That transition between healthcare setting, reducing those adverse drug effects, and those possibilities of inadvertent prescription or administration of drugs because you don't know what else they might have had or what else they might be taking. So the HIE provides you all that information to help you with that. And the big thing this does is really provide the data to improve outcomes and support for healthier Oklahomans. So, so this is a fact that I have here at the bottom. Greater than 90% of Oklahomans have records in more than one health system. So our care is very fragmented, right? It's actually the average is probably around 5. And you actually see some data later from Dr. Kendrick that kind of supports that. But so and I know when I go from orthopedic to primary care to cardiologist, it's always, they just seem to never be able to communicate. And that's what the HIE is all about, is be able to see those records wherever you go. So I have some common questions. We've done this presentation many times over the last year and a half, and I've kind of developed these sets that I always get asked, just kind of help you with that. So the first question I get a lot is, how are participation fees calculated? Well, they're organized by the type of organization and the size, so they vary depending on those. And connection fees, the connection fees are the cost to actually connect to the HIE, to take your EMR and connect it, are all paid by the state. So we have a state program right now. You'll learn more about that in a minute, that will pay those connection fees and can reduce that cost to really zero. And then there are other incentives available. And for certain provider types, which you'll learn about a little bit in a minute, all your participation fees would be covered in the HIE. And in fact, you probably will exceed those, and you'll actually make money by being in the HIE. From privacy and security, I talked already a little bit about that. It's all HIPAA compliant. All the SDE policy, this SDE stands for State Designated Entity. That's what MyHealth is for the state of Oklahoma. All those policies are actually more restrictive than HIPAA, and providers must be in a treatment relationship to access the record, and they actually attest to that. And we audit that on a common basis. We take in no substance abuse, 42 CFR Part 2 data. We also do not take psychotherapy notes, and those are restricted from delivery into the HIE. The other feature that we offer is providers can mark charts as sensitive. So if you have a particular encounter or a particular chart you don't want to send to the HIE, that's your choice as the provider, and you can set that as a sensitive chart. And then, of course, I said earlier, the SD technology is all high trust certified, and they've been operating this system well over 10 years without an incident. The last thing I like to really point out is this is a choice system. Providers have a choice and patients have a choice. So all patients have the right to opt out at any time. They can do that at any participating or organization in the HIE, or they can go to MyHealth or the state's website, and they OKSHINE.ok.gov, and you can opt out there, fill out an opt-out form, and you can prevent all disclosure of that. There used to be, if many of you have any history with the HIE, we used to have what we call a break the glass rule, meaning that the data was actually sent, but then an ER doctor in a life and death situation could actually break the glass and see the record. That only happened 2 or 3 times in over 10 years. So we made a decision, because of some of the controversy it was causing, to just stop that. If you do an opt-out, your data is not disclosed. The other thing I like to point out is that mental health patients must affirmative consent to any data being sent. So if you're a medical patient, you'll still see a notice of privacy when you go to the doctor. It'll probably disclose that they use the HIE, but unless you specifically say and do an opt-out, your data will flow. However, if you're mental health, it's the opposite. You have to, as a mental health patient, affirmatively consent that you are okay with that data going into the HIE. If you don't, that data is not sent. And lastly, providers have a choice. So we went through, and you'll see some of the legislation in a minute. We had a mandate at one point that all providers had to connect to the HIE. We've changed that. It's now any provider can request an exemption. And if you request an exemption, I'll grant it. Not going to spend a lot of time on this. These are the primary sets of legislation that have been going over the last 3 or 4 years. Of course, 1369 is the big one. It created this Office of State Coordinator. It designated that we would outsource the operations of the HIE to a state designated entity, in this case, MyHealth. Had some tort protection in there as well. So if physicians don't use the HIE or use the HIE and get inaccurate data, they can't be sued. And of course, it declared that all providers would participate. that was later with 3556. You see at the bottom that amended for all providers may. So and we had been granted exemptions for some time. 32X here in the middle actually was the $21 million we have for one-time connection fees. We also just note that the managed care entities also are required to submit to the HIE. Okay, let's talk a little bit about incentives. So the big one we kind of mentioned already is connection fee assistance. So this is that cost that typically your EMR provider may have a fee for connecting. There'll be some labor involved from my health to get you connected. All that work to get you physically your EMR connected and all the parameters set and all that is we'll pay for under this program. So we have a grant program. You can apply for that online at okshine.ok.gov. It's a very simple process. It doesn't take but a minute. And I highly, highly encourage everyone, if you haven't already applied for a grant, do so, even if you're not sure, because this money could disappear at any time. And if you have already applied, I think that we'll be able to take that encumbered funds and hold it rather than just losing that funding. So I would highly, if you after today, if you think this is something you might be interested in, go ahead and at least doesn't commit you in the end game to doing anything, but just get you registered for one of these grants. The second incentive we have is the SoonerSelect Provider Incentive Program. So this is only available for SoonerSelect or managed care. So you have to be treating patients in the managed care program with one of the MCEs. It's only these particular provider types that you see listed here. And there are some exceptions, as you see here, the community health centers, state employed or contracted physicians, FQHCs, rural health clinics, IHS, tribal, and services for Medicaid population that's not in SoonerSelect, so ABD and so forth. So those are excluded. The reason they're excluded is there are other directed payments programs for these areas already, and CMS says we can't pay multiple directed payment programs to the same entity. So that's why that is. A little bit more about this. So if you're in this program, just for being a part of the managed care Medicaid program or the SoonerSelect program, you will receive 18.5% base fee schedule increase for all those providers and their billings that are in SoonerSelect. So 18.5% base fee schedule increase. On top of that, if you're in the HIE, if you've signed up for the HIE, you'll get an additional 9.25%. And it's not, we've made this fairly simple. You have to be a member in good standing. That just means you have to have all your agreements signed and be up to date with the SDE. And you have to be live or demonstrating in progress, which means if you've got your grant and you have at least had a kickoff meeting, that counts. So when we've got several that have joined over the last 3 or 4 months who are still in the queue to get onboarded, they already have portal access and some of those things, but actually sending data is taking a little more time to get their EMR scheduled. But we're doing payouts on those all. We're not currently in these first 3 quarters, likely till the end of this program, not going to require a utilization metric. Really, this is all you have to do is sign up and get connected. But in the future, we already know CMS has kind of said you need to actually have some utilization, show that you're actually using the HIE. And there's a lot of new features out there that are going to make that even easier for you. And we'll talk more about that in a minute. We didn't actually get the second quarter payouts integrated here, but I can give you an idea here. This is just examples of some of the payouts. So here's a major hospital system. They total SoonerSelect payout $664,000. HIE piece in addition to that was $221,000. Against their participation fee for that same quarter of $71,000, you can see they made $150,000. You can see that's even the single small clinic group who had one provider, got a payout of $424, and their participation fees were $165, so they even made money. Now, if I could show these numbers, before I got on the phone, this same hospital system in this second quarter received looks like $744,000. Okay. No, I might have that wrong. I think that they actually received $2.8 million, and their payout in HIE was $664,000. That's a big deal. That's a big deal. So in any case, it is when these payouts went up substantially. The first quarter payout, we're still trying to get the data right. We're trying to get a lot of that's early into the managed care program, and so not all the claims had processed through. Now that we have all that resolved, we're getting the maximum payouts in many of these areas. So I highly encourage you to get in. This program won't last forever. We hope we'll be able to extend it, but and I'll talk to you more about that in a minute. Here are a little more detail on who's eligible in those provider types. This is a little more detail on each of these. There's several of these, and these will be in the slide deck that if you want to download it. You can see every type of physician, every type of specialties is covered, particularly in the physician area. Licensed behavioral health practitioners are also covered. Anesthesiologists are covered, and so forth. Okay, HIE progress and framework. Let's talk about kind of where we've come from. So states were kind of involvement and restart of the HIE was in September of 2022. Since at that time, we had about 18,000 unique hits to the HIE every month on average. Today, we're over 50,000. That fluctuates some, but we've really increased this substantially. So there's a lot of utilization going on. Over 500 organizations have joined. That's over 200 just have joined in the last 2 years or year and a half or so, particularly since the incentives came out. Just FYI, all the SoonerSelect dental and medical MCs are contracted, trained, and connected. So they have care coordinators using the HIE. They're also using the ADT capability for that, and care fragmentation reports. So they have a lot of capability there. And I might also mention one of the ways that the healthcare authority uses the HIE is all of our Medicaid patients, every night we get a care fragmentation report or an ADT that tells us where they've landed. If somebody just landed in the ER, somebody just exited the hospital, somebody just got admitted to the hospital, and that allows our care coordinators to real time that next morning reach out to those individuals and see what kind of care or assistance that they might need. If we didn't have this, we'd be looking at claims data to be 30 to 45 days old at the best. So this is a very, very great system for doing that. There's all kinds of these type reports that we'll talk about a little bit later, but that you can get from HIE in addition to just getting access to the records. Connection fee grants, we've awarded 422. That's over 200. When we have over 200 organizations that are actively in the process of connecting, we're optimizing that process, trying to streamline it as best we can. And I want to point out that all EMR connection fees are now eligible for reimbursement. So, if you're, there's a limit, obviously. EMR providers, they can't go and just charge anything. But if it's within a reasonable fee, and we have enough history with this that we kind of know what that reasonable fee is, then we're going to pay to get them connected. And then lastly, those directed payment programs I talked about earlier. So you can see in Plan Q1, we issued $12 million in payments. That's $10 million for the Medicaid participation. That's $2 million for HIE. In Plan Q2, payments issued are $37 million or $30 million approximately for Medicaid participation, over $7 million for HIE participation. I think we'll see this continue to grow. There's $132 million that will be paid out between now and July of 2025. So I'd encourage you to get in as soon as you can before this money runs out. Um, of course, My Health is statewide. They have many participating areas. They are a 501c3. They have over 5 million individuals in the HIE database, and 12 years of historical data, and a lot of SDOH data, which David will talk about more in a minute. Here's the framework. Here's how this actually works. So you'll see all the clinics or facilities here at the bottom. They send their data through their EMR, through the data gateway layer. That data is kind of like the holding layer, where kind of the generic layer where we can process that data. That's picked up by the SDE, in this case, MyHealth. And MyHealth does all the day-to-day operations of the HIE. They do all the governance, they do all the testing, they do all the assistance to the providers, and really make this thing work. They also operate the technology layer, which is the portal. And David will give you a brief view of this in a minute. And we also are SSO integration layer, which I'll talk about in a second, or he'll talk about in a second, and our EMPI layer, which matches the patients properly. My office, the Office State Coordinator, we do all the program oversight. We coordinate all the other state agencies who use the HIE, and we do some reporting and analytics. And big thing we do is look for funding sources. We want to make this as lowest cost as possible. At some point, I'm hoping it will be free, but at this point, I think we've got some really good value to provide these entities. So just to kind of break it down off the state coordinator, this is kind of where the line is. We do all the oversight. We seek funding. We represent the SDE. We oversight on SDE, and the state designated entity does all the stakeholder governance, establish policies. They do the outreach and onboarding, and they ensure the patient's rights are protected and data is secured. Here's just some few things that people say about it. I like to point out while you're reading these, this Net Promoter Score. If you don't know what that is, basically that's a ranking or a way to rate customer satisfaction, particularly around technology companies. This plus 38 is an incredible number. This is like at the level of Apple Computer. And at one point I worked for Cerner, and I remember when we got to a +1 and we were all having a party. So, I mean, this is a big deal to be this. And so people are very satisfied if they're using the system. And you can see some of these examples here, whether you're a clinician or a care manager. There's lots of really good use cases for the system that go well beyond just the access to records. So with that, I'm going to turn it over to Dr. David Kendrick. He's the CEO of MyHealth and have been involved in this since day one, and I'll let him take it from here.
Thank you, Steve. All right, let's go to the next slide. So MyHealth offers quite a range of services, which you can see here on screen. And there are even more than this, but we'll start with these. You can see around, I'll just cover them quickly. We do condition of participation notifications. So if you're a hospital or organization that's obligated to deliver those, MyHealth can do that for you. We support public health reporting. We provide social determinants of health screening, which I'll tell you more about in a moment. Clinical and claims data integration. MyHealth is the voluntary all-payer claims database for Oklahoma as well. And as such, we have the claims data as well as the clinical data on Oklahomans for most health plans. Quality and care gap management. I'll tell you more about that in a moment as well. And then care coordination, records aggregation is where we'll start. Next slide. So the access to medical records in MyHealth it's critically important, as you know, in a busy clinical workflow to make this seamless. And so we've begun rolling out now a single sign-on strategy so that when a provider or user, someone with rights to access the data, is in their electronic health record system, they have a link that they can click that's either called MyHealth or HIE or whatever they decide to call it in their system. And that will spawn immediately access to the patient's chart that's currently in context. So if you're looking here at Jane Test, I guess is the patient, in your EMR and push that button, then you'll be looking at Jane Test's record in MyHealth. So that saves the need to go to the web page and log in and search for the patient. and really cuts down on the number of clicks and enhances rapid access to the data that might be needed. Next slide. And so our provider portal is a little bit different. If you're used to interoperability of health data, say through Care Everywhere or Commonwealth or one of these federated models where you need to tell it what hospitals you want to look at and you have to go get the documents and bring them back. MyHealth is set up differently in that all that data is pushed to us actively and usually in real time, so that we're always accumulating the most current health records on the individual patients and organizing them so that it's not a matter of opening and reading documents, which drives me crazy at the point of care, because all I need is the latest blood pressure or the latest A1C or some recent lab test. And I find myself opening and reading a bunch of 50-page documents to figure out what that result is. Well, in the MyHealth system, we've already separated out that data into its components, like a single list of labs, a single list of medications, allergies, and so on, so that the user has much easier access to the data. And also they have access to data that they may not have known they needed to go look for. If it's a patient coming to see me because they survived the ER visit, that's one thing. But if it's a patient who's called me and I need to know about the things that have gone on since I last saw them, much easier and faster to review in the MyHealth portal. This is also helpful for closing loops on referrals. So if you happen to be in primary care or an organization that's sending patients other places, the MyHealth portal should show you whether that patient made it to the cardiologist or the dermatologist or whatever, and so that you can appropriately plan follow-up. Next slide. So within the patient chart summary, there are a full range of types of information. You can see a set here that is the kinds of things we use to drive clinical plan making, goal setting, and decision making. And I'll add to this some new data elements that have started to be tracked in the system, which include plans of care and patient goals and so on. So we're always keeping up with something called USCDI, which is the federal standard for the data that must be exchanged. And that every year that gets expanded a little bit. And so we make sure to enable your provider organizations and others to stay in line with USCDI by accepting that data and presenting it back. Next slide. So this is an important slide to understand. This is data from about 12 of the 75 health information exchanges around the country. And what it shows is the number of patients in the various networks. And you can clearly see Oklahoma there in the middle. And it's all red, meaning basically 100% of the population that lives in Oklahoma has at least some medical data in the MyHealth system. You can see Nebraska. Their network is called Sync Health. They have a lot of data density in Indiana and so on. And if I had all 75 of the networks on this map, it would all be red. But the most important message here is to see that together these networks cover basically the whole nation. Even just this small sample of networks covers almost 100% of US zip codes and about 135 million lives. But if we zoom in, if we can click on the next slide. Let's zoom in on Oklahoma for a moment and just check one zip code. So this will be the people who live in one zip code in Oklahoma. Go ahead and, oh, I don't see the build. Doesn't look like it's showing.
I think we hit it, sorry.
Oh, that's okay. So what I can tell you is that as you know in your own lives and certainly your patients, people get care when they need it and where they need it. So if they happen to be on vacation or traveling for work or be a student somewhere, then they are going to get care in that place. And MyHealth is a part of a network called the Patient-Centered Data Home that routes that data back to Oklahoma, so that if anybody, so for anybody who lives here in Oklahoma, even the care they received in Arkansas or Texas or California will be known to their provider in Oklahoma, so they can get comprehensive care and have all their data together in one place. Next slide. The other thing that I want to point out that's maybe not intuitive, especially if you're on the healthcare provider side, we look at our EHR systems and we see a ton of data, right? We see almost more information than we can review about the patient. The problem is that that's not all the story on the patient. In Oklahoma, because My Health has a lot of what I'll call data density, meaning we have most of all the clinical data for most of the people in Oklahoma organized in one place, we can also measure how fragmented everybody's record is. And so what this chart shows is a series of histograms for the 6 largest health systems in Oklahoma. So one of these is Integris, one of these is St. Francis, one is OU, one is Mercy, and so on. And the numbers across the bottom here, the x-axis, show how many places patients have data. So let's take the 5 column there and look at health system F. And what this chart shows is that 15% of the patients that health system F takes care of have data in 5 places, right? So that means that for any patient that walks in the door at health system F, 15% of the time that patient will have data in 5 places. And what that means is really the most important column to look at is the 1, because that's the percent chance that a patient walking in the emergency room or coming to see me in clinic in that organization has all their data already in my EHR. And you can see it's a very low percent. So we're talking about between 96 and 99% of the time, 98% of the time, I'm going to need data from outside my health system in order to take care of this patient. And I think that's something that is often missed when we look at our EHRs, and it appears to be complete, but we need to understand it is not complete with the patient story. Next slide. So the next thing that we're often told is, well, I have Epic or I have Cerner or whatever. But by having Epic, I'm able to connect to all the other Epics and get data from them. Guess what? This is the top 6 EHR systems in Oklahoma. One of these is Epic, one is Cerner, one is Meditech, and so on. And what you see here is that the fragmentation is the same. Even if I had all of the data from Epic on a patient, on the patient sitting in front of me, I would still only have somewhere between 3% of the chance that I have all the data and a 1% chance that I have all the data. So the point here is, even if you're on a particular EHR vendor, there's little chance you're going to have the full story on a patient, and we need the network, the health information exchange, to bring the most full picture to the table. Next slide. All right, so there are a lot of other functionality capabilities on that chart, but I'm going to zero in on one that's become really important lately. Social needs screening, as you know, is now part of the Joint Commission accreditation. It's a HEDIS measure, so health plans are starting to really focus on it and put it into value-based payment models. And it's also a part of meaningful use as one of the MIPS measures. So My Health started doing work with social needs screening a long time ago, starting back in 2016, and we have developed and deployed across the state to any organization that wants it, social needs screening that's based on a mobile approach. And go ahead and click to build this out. So the challenge that's faced, of course, is it takes staff time to do the social needs screening. And then when you discover the patient has a food need or a housing need, it takes yet more staff time, social worker time, to match the patient with resources that can meet their needs. And what I will say about that is that though we all have good intentions as healthcare providers to try and help these patients meet their needs, it's not in our wheelhouse, it's not our core work, and it takes away from our core work. So My Health developed this method that enables providers to raise their hand and say, please turn on this screening for my clinic or my hospital, and My Health will turn this on so that when we get a registration event from your clinic, we will deliver this screening to the patient's mobile phone based on their registered phone number. And they complete the screening somewhere between 20 and 40% of the time. And we score it immediately. Next click. And if they have a social need, we will also give them 3 options to meet each social need based on where they live. So we'll give them 3 food pantries, or a food pantry and a food bank and a SNAP application, something nearby where they are. We'll give them access to housing resources or utilities. And so we not only detect the need, but we help to address the need. And then if an organization wants to subscribe to it, we can provide a report back indicating the needs that were detected and addressed in their patient population. This program has won a lot of awards, won some national awards, has had a big impact. These are numbers through September of 2024, and I'm happy to say we've now made more than 5 million offers to screen for more than 1 million unique individuals in Oklahoma. And we find that needs tend to travel together. If somebody has one social need, they probably have multiple social needs. And we're able to deal with the social needs issue right up front, whether the patient's in your waiting room in clinic or they're sitting in the emergency room at 3 a.m. Next slide. So the provider portal, what's coming next is we've now got the governance approval to add these social needs results to the portal itself. So that's another piece of information you'll be able to get when you go to review the patient's chart. In addition to a single list of medications, a single list of allergies, and so forth, you'll be able to get the history. Next slide. Of their social needs screening here to show you what was the screening that was done, what was the domain of screening, and what was the question and the answer for that, on top of, in general, what need did they have. Next slide. So there's little question about the value of health information exchange for providers. It all really comes down to being able to access what I didn't know so that I can provide comprehensive care to my patients, and also to have that available to me both in real time and also to have that information pushed to me through alerting and so on. So in addition to the things on this slide, which I'll let Steve cover, I want to mention a couple of use cases that have been in the literature recently. In one case, a health information exchange was measured the impact of a primary care provider opening the health information exchange chart for patients that were discharged from the hospital, and they demonstrated more than 60% reduction in 30-day readmissions among those providers that actually reviewed the chart after discharge. Another use case that we've recently demonstrated in our community for transfers of patients from outside facilities, say to a tertiary care center, when compared with Epic's Care Everywhere. Epic Care Everywhere provided data on about 14% of requested transfers, whereas looking in MyHealth's provider portal provided meaningful data on more than 60% of requested transfers, enabling that transfer to happen more quickly and with a better plan in place. And I'll turn it back to you, Steve, with that.
All right. I did stick just a couple of slides on here on participants. You'll have this also if you go to MyHealth's website. I think they have a pretty good list of active participants. It's pretty extensive. The people who are currently participating in MyHealth, it's growing every day. We're averaging 10 to 15 connections every month getting connected, and grant wise we're getting probably 20 to 30 grants a month. So those are continuing to grow. But what I really wanted to point out is this is a really pivotal time in Oklahoma. State funding's never been greater. This is the best time to get in the HIE. We've got lots of cost pressure. We all have cost pressure. Managed care entities, we all have cost pressure. And we have some great incentives to get providers connected and using the system. There are a lot of not only, certainly financial reasons, but the biggest are clinical reasons, as David just pointed out. And never before could you connect at no cost. If you're one of these provider types and you see any substantial amount of Medicaid patients, your costs are probably going to be totally covered. And I encourage you to reach out to MyHealth or to OFMQ, and they can actually look at those numbers. They can tell you exactly what kind of incentives you're going to get and help you with that. The risks we have is, I had a great meeting with the legislature, a subset of the legislature yesterday. It went very well. However, we never know what's going to happen with this funding. So that could change tomorrow. There's going to be a lot of demands on funding. It's going to be a really tight year for all the state budgets. So I encourage you to get in there, get your grant at least applied for. You'll get a confirmation with that usually within just a few days. And then you'll be in line, and your dollars will be set aside for those. So I really ask for timely action where if you think you're interested in this, like I said, you're not committed in the long run, but in the short term, that gets your money set aside. The other thing I'd say is, this is a really great system. It does really improve care coordination, a capability to really enhance your assessment, close those gaps in care, enable better follow-up, enhance your overall care management capabilities and care coordination. It can reduce the cost of care. It can address social needs and gives you really timely access to care and services. Really, we really believe the HIE provides a path to information for healthier outcomes of Oklahomans. So with that, I think I'll just open it up. I don't know if we have some questions online already that we want to answer. Lindsay or Rebecca, how do we want to handle that?
I think we can go ahead and take questions if anybody has any.
Yes, in the chat, we have put, Sydney with My Health has put the link to apply for the Connection Fee Assistance Program and also more information for the SoonerSelect Incentive Program and to learn about OKSHINE. Right now, Rebecca, I don't think I'm seeing anything in the chat. You're welcome to put something in the chat. And I think you can come off mute and ask a question as well. Oh, there we go. There's contact information for both Steve Miller and Dr. David Kendrick. There's more website information and contact information with emails. We are so glad you were able to join today. We hope this was helpful. We're really trying to get the information out to everyone. So please pass this information along. We will do a follow-up email and send these slides out to everyone to make sure you have a copy. And again, you can share those within your organization or even through your network to get this information out. If you have any questions, please email us. We'd be happy to answer them. We'd be happy to speak at different events that you might know of or be a part of. So please help us spread the word, and we are available if you need us. I do see a question. Are we able to receive a copy of the presentation? Yes, I believe so. After this, we will send an email thanking you for attending, and we will attach a PDF version of the presentation. So we will absolutely do that. I see 2 questions, and then Sydney replied, yes. So we'll get that to you guys.
Lindsay, I see that there's also a question in the Q&A portion.
Oh, thank you so much. I get stuck on that chat and I forget. Thank you, Chad. Can you explain how, if a patient receives care out of state, how those records are received by My Health?
David, you want to take that?
Yeah, sure. So the patient-centered data home model, the way it works is My Health is obviously a nonprofit organization based in Oklahoma. And starting in 2015, we partnered with about 40 other networks around the country, like My Health, that are based in their states or regions. And they serve the same role we do for their communities. And we established trust agreements among our network such that if a patient, say, goes to Arkansas, and their network is called Arkansas Share, and Arkansas Share receives a registration event, and in that registration event, the patient reports their home address being in Oklahoma City or Tulsa or really anywhere in Oklahoma, then the Arkansas network packages up that data and routes it directly to us. And what that enables is, not only availability of the data from across, state lines and another network, but it also does that in real time as a push. So if you're a subscriber to My Health's care fragmentation alerting or any of the alerting packages that notify you when your patients have received care somewhere outside of your organization, these out-of-state notifications will be there as well. The other sort of nuanced thing about this model is, state laws around privacy are different in every state. And so this enables the Arkansas network to ensure that Arkansas's laws are met with how data is handled and so forth. And when data comes to My Health in Oklahoma, we can ensure that all Oklahoma state laws and policies are met as well, so that everybody is covered and patients are appropriately protected.
Thank you so much, David. Katie, if you have any other questions, please feel free to shoot us an email and we can schedule a call and answer any other questions you may have. Right, I think that's all we had in the Q&A. And I believe we are caught up on the chat as well. Thank you guys so much for joining. Again, please reach out. We're happy to connect with you and we're happy to answer any questions that you may have and help you get signed up in any way. Thank you everyone for joining. Thank you, Dr. Kendrick, and thank you, Steve. We appreciate everyone. Have a
Thank you.
fantastic day. Bye,
Thank you,
guys.
everybody.
Bye.